Pancreas is an endocrine tissue that is required for the production of different hormones. And here in this islet of Langerhans, you have alpha cells which are in the periphery and are shown in red. So these are called alpha cells, which are required for the production of the glucagon. And the main function of glucagon is to increase blood sugar by increasing the gluconeogenesis as well as glycogenolysis. On the other hand, in the center, you have the cells that are called beta cells. And beta cells are responsible for the production of insulin, which increases the uptake of the glucose by muscle and adipose tissues via the GLUT4 transporters, and at the same time it increases the production of glycogen, protein, and triglycerides in the liver, as a consequence of which the concentration of blood sugar goes down. So therefore the balance between the insulin and glucagon will determine the outcome of the metabolism. Now I would like to go over the mechanism through which the beta cells secrete insulin. So once there is an increased concentration of the glucose, there would be increased concentration of ATP, as a consequence of which it acts on the ATP dependent potassium channels and causes their closure. So once potassium channels are closed, it will cause depolarization of the beta cells, as a consequence of which they will secrete insulin. So anytime there is an increased concentration of the glucose, body will respond through this mechanism and will secrete insulin. Now there are certain thresholds for determining someone is having diabetes, and the thresholds are shown here. So here the numbers are given in millimolar per liter, and then by multiplying them by 18 you can get milligram per deciliter. So first look at the fasting blood sugar. So if someone is fasting, normal is to have a blood sugar of less than 5.6, and if you multiply that by 18, that would be 100 milligram per deciliter. So normal fasting blood sugar should be less than 100 milligram per deciliter. For pre-diabetics, it's 100 to 126. So if you multiply 7 by 18, it will give you 126. So that would be pre-diabetic. And if someone is diabetic, their fasting blood sugar would be more than 7, which is the same as 126 milligram per deciliter. So their blood sugar would be more than 126. On the other hand, if you check the random blood sugar, then these would be the values for pre-diabetic, which would be 7.8 to 11.1. And if you multiply that by 18, that would be 140 to 200. So that would be the pre-diabetic concentration of random blood sugar. If it's more than 200, then the patient is diabetic, and if it's less than 140, then the patient is normal. Now the way you can memorize these numbers is to memorize this phone number that is provided here, 567, that would be the area code, and then 78111. And I call it pre-diabetic number because by having this number you can know all the values that are listed here for pre-diabetic. So for fasting blood sugar between 5.6 and 7 would be the pre-diabetic number. And then for random blood sugar of 7.8 to 11.1 would be the random blood sugar. So just memorize this number and then you can get these values, and if you multiply it by 18, every value, you will get them in milligram per deciliter. There is also the hemoglobin A1C value, and this hemoglobin A1C shows the glycosylation of the red blood cells. And so the red blood cell lifespan is about 3 months. And over this period, the hemoglobin will become glycosylated. So once you measure the hemoglobin A1C, it will give you a measure of blood sugar control over the past 3 months. And the normal number that we are aiming for is less than 5.6. Pre-diabetic would be 5.6 to 6.5, and in diabetic patients it would be more than 6.5. So in diabetic patients, we are hoping to bring the value less than 6.5. Now speaking of the sugar control, I would also like to remind you that for diabetic patients, the goal for blood pressure is less than 130 over 80 millimeter mercury. So 130 systolic and 80 diastolic. That would be the goal of blood pressure for patients that have diabetes. And if someone is having a blood pressure that is higher than this value, ACE inhibitors are the drug of choice to decrease the blood pressure, and the reason for that is that ACE inhibitors will decrease the perfusion of kidneys, and thus it will decrease the damage in diabetic patients made to the kidneys. So just keep that in mind. 130/80 is the goal for blood pressure in diabetic patients. If it's above that, we'll correct that by ACE inhibitors. Now, let's go over the mechanisms of diabetic mellitus and the two types that we have here. So the first type is caused by the lack of insulin. So there is no insulin production whatsoever. It has nothing to do with the sensitivity. And it comprises about 10% of the cases of diabetes, and it's usually seen before the age of 30. On the other hand, type 2 is associated with 90% of the cases of diabetes mellitus. It's usually seen after the age of 40, and it's associated with central obesity, and genetics is playing an important role in the development of diabetes mellitus type 2. For type 1, it also plays a role, but not as significant as type 2 diabetes mellitus. And then type 2 diabetes mellitus, the main cause of it is decreased insulin sensitivity. So for type 1, there is lack of insulin production because of the destruction of the beta cells in the islets of Langerhans, while in the type 2 there is decreased insulin sensitivity, which is associated with obesity. So with type 2, usually people, if they lose weight, they can gain back their insulin sensitivity and then they would be normal. I would also like to go over the pattern of insulin production with type 2. So initially there would be an increase in insulin resistance. And then the body responds by increasing the insulin production. So initially body will increase insulin production, but eventually the pancreatic cells will exhaust, and thus the insulin production will go down eventually. So first there would be a spike, and then later on the production of the insulin will go down in these patients. But anyway, back to the topic. I would like to continue over the mechanism through which type 1 diabetes mellitus develops, and it's usually autoimmune and is associated with HLA subtypes of DR3 and DR4, and these patients are positive for anti-glutamic acid decarboxylase antibody. So glutamic acid is present on the pancreatic cells, and once these patients are forming antibodies, it will attack the pancreatic cells in patients with type 1 diabetes and then cause destruction of the beta cells, as a consequence of which there would be lack of insulin production. And once you obtain a histology of these patients, you would see a lot of leukocyte infiltrates in patients with type 1 diabetes mellitus. On the other hand, in patients with type 2 diabetes mellitus, on histology you will see amylin products. So amylin is a protein that is produced alongside with insulin, and thus it will deposit in the islets of Langerhans in patients with type 2 diabetes mellitus. Next, I would like to go over the complications of diabetes mellitus. So these patients, whether it's because of the lack of insulin production or decreased insulin sensitivity, will develop hyperglycemia. And if there is stress, then there would be increased production of growth hormone, cortisol, as well as epinephrine, all of which will further increase the blood glucose. So therefore, if there is stress in patients with diabetes, the hyperglycemia will be exacerbated. In addition, these patients will have polyuria because of osmotic diuresis, and so they would drink a lot of water to compensate for too much urination. And then another complication is diabetic ketoacidosis, which is seen in type 1 diabetes mellitus, and hyperosmolar hyperglycemic state, which is seen in type 2. So patients with type 2 rarely develops DKA because they still have some insulin production, as a consequence of which they won't develop DKA. While type 1, since they don't have any insulin production, they're prone to developing diabetic ketoacidosis. In any case, patients with DKA will present with triads of hyperglycemia, ketonemia, and the two major ketones that are present in the blood of these patients is beta hydroxybutyrate, which is the most abundant one, and then acetoacetate would be another one. And then finally, metabolic acidosis with increased anion gap is a sign of diabetic ketoacidosis. So there's 3 signs for diabetic ketoacidosis. And then the metabolic acidosis with increased anion gap is because of too much ketones in the blood. In addition, I would like you to note that the hyperglycemia in these patients is usually less than 800, while in patients with smaller hyperglycemic states, it's usually more than 1000. And then one other factor that you should be familiar with is that in patients with DKA, since they have metabolic acidosis, they would develop Kussmaul respiration. So let me go here. So they would develop Kussmaul respiration. So since there is metabolic acidosis, by Kussmaul respirations, which are deep and rapid breathing, they will try to compensate by exhaling as much CO2 as possible. So again, deep and rapid are the two mechanisms through which patients with DKA are trying to compensate for metabolic acidosis. Now, I should also mention that these patients will present with hyperkalemia, and the reason for that is that there is too much H+ in the extracellular space, as a consequence of which cells will exchange H+ with the K+. So K+ potassium stores from inside the cell will shift extracellularly, as a consequence of which it will cause hyperkalemia. And once you correct for the metabolic acidosis in these patients, potassium will again shift back into the cells. The next condition, as I mentioned, it is hyperosmolar hyperglycemic state, and as I mentioned, in these patients usually blood sugar is more than 1000 versus DKA, which is usually less than 800. So in these patients, they would develop with high blood sugar but no ketoacidosis. And for the treatment of both DKA and hyperosmolar hyperglycemic state, you must first give IV isotonic saline, which is 0.9% saline. And once you gave IV saline, the next point is to check the levels of potassium, and if needed, supply potassium in these patients. So you may wonder, why would we need to give potassium in these patients if they are hyperkalemic? And the reason for that is that this hyperkalemia is from the intracellular stores, and since there is osmotic diuresis, so much of this potassium will be excreted in the urine, as a consequence of which these patients will lose a lot of stores of potassium, which is from the intracellular space. So once you give these patients IV insulin, potassium will start to shift back inside the cells, and now there is not enough potassium, and thus it can cause hypokalemia. So at the same time, you must always check for the potassium levels in these patients before you give IV insulin. And then once you give IV insulin, you have to continue giving IV insulin until patients become alert and the anionic gap is corrected in these patients. So let me summarize again. The first step in patients with either DKA or hyperosmolar hyperglycemic state is to give 0.9% IV saline so that you correct for the loss of fluids. Once you did that, check the levels of potassium. If they're on the verge of being hyperkalemic, supply some potassium, and then later on give them IV insulin until patients become alert and their anion gap is corrected. And if you recall, the normal anionic gap is 8 to 12. So your goal is to bring the anionic gap less than 12 in these patients. Next, I would like to go over the complications of diabetes mellitus. So all the complications that I've listed here for number 1 are due to the non-enzymatic glycosylation. So once proteins are becoming glycosylated, it will damage the blood vessels, as a consequence of which these patients can develop hemorrhage or microaneurysms in the retina, and which will cause retinopathy. Alternatively, since there is again glycosylation of proteins in the retina, it will cause the leakage of fluids out of the vessels, as a consequence of which it can cause macular edema. Likewise, due to the arteriosclerosis of the nephron vessels, these patients can develop nephropathy and presents with the Kimmel-Steele-Wilson nodules, and then the first sign of diabetic nephropathy is microalbuminuria. So if on the exam they ask you, a patient is presenting with diabetic nephropathy, what is the first sign that will present in these patients? Is the microalbuminuria. And then here would be an example of the Kimmel-Steele-Wilson nodules. So here you can see the sclerosis, the hyaline formation in the glomerulus. And then here is an example of a patient with diabetic retinopathy. There would be extra vessels that are formed in these patients, and then they would eventually cause hemorrhage and could lead to the blindness in these patients. So here you can see that there is a lot of hemorrhage here in the center of the retina. So let me change color. So here again, you can see a lot of hemorrhage here in the center of the retina. And how you can treat these patients is by the laser photocoagulation of the periphery. So you will burn the periphery so that there would be less vessels formed, and thus there would be less complications of the diabetic retinopathy which results from the hemorrhage. In any case, back to the first topic. So all these conditions, diabetic retinopathy, nephropathy, as well as cardiovascular accidents like heart attack or strokes, are all due to the non-enzymatic glycosylation of the blood vessels. The next two conditions that are listed here, like cataract and peripheral neuropathy, is due to the buildup of the sorbitol. So glucose is converted to sorbitol via the enzyme aldose reductase. So just keep that in mind, that aldose reductase converts glucose into the sorbitol. And then later on, in some tissues which will have the sorbitol dehydrogenase, sorbitol will be converted back into the fructose, and it doesn't cause damage. But if a tissue like the lens of the eye or the peripheral neurons doesn't have the sorbitol dehydrogenase, as a consequence of which sorbitol will build up and causes osmotic damage. For instance, there would be swelling of the lens fibers, or there would be the neuronal death in these patients, as a consequence of which they would develop stocking and glove loss of sensation, or they may alternatively present with tingling sensation in the extremities. So again, keep that in mind, that cataract and peripheral neuropathy are due to the buildup of sorbitol in these patients. And sorbitol is produced from the glucose via the enzyme aldose reductase. And then the final complication in these patients are infections. And infections that are common in diabetic patients include the Klebsiella pneumonia, malignant otitis externa, which is caused by Pseudomonas, and this Pseudomonas will affect the external auditory canal, and it will also attack the skull in patients with malignant otitis externa. And then the final complication is mucormycosis. So mucormycosis, which is caused by the fungi mucor and rhizopus. So in patients that have DKA and there's a lot of ketone in the blood of these patients, these fungi can grow in the blood and then attack the brain via the cribriform plate. And thus eventually they will enter the brain. So there we go. So they will eventually enter the brain and cause cranial nerve damage. So on physical examination, you will see a black eschar in patients with mucormycosis. So this is a very serious condition that will be diagnosed with the MRI of the brain and must be treated with surgical debridement and systemic treatment with the amphotericin. And that concludes our discussion.